Hey everyone, I'm Karl Saardi. I'm one of the dermatologists here at George Washington University. And I was going to talk about some of the developments and challenges in protoporphyrias, as well as have a short Q&A session. I got involved in protoporphyria through my interest in blistering, disorders of the skin and other porphyrias too. There was someone in the area, who was taking care of the majority of the patients with EPP, and due to some, restructuring and a buyout of his practice, we ended up transferring, the care of a lot of those EPP patients over to my clinic in George Washington University.
I'm so sorry to interrupt you, Dr. Saardi. I'm having a little bit of trouble hearing you. I just want to make sure everyone can hear you okay. I apologize for interrupting.
Does it sound okay now?
Yes, that's great. Thank you.
All right. So what is porphyria? Porphyria is a group of medical conditions where there are issues on how the body makes hemoglobin. Usually they're genetic, but some of them can be the result of another medical condition. Hemoglobin protein is made of heme molecules that contain iron and transport oxygen throughout the body. Heme production it's a complicated series of chemical reactions, and porphyrins are the various molecules that represent each step in making heme. Porphyrins are activated by certain types of light, and they can cause damage either when they absorb certain light and give off that energy, damaging cells, or they can just accumulate in various internal organs, including the nerves, liver, etc. So the symptoms in each type of porphyria depend on which step in this process is, quote unquote, stuck, and what type of porphyrin is building up in the body, and where that porphyrin is accumulating and what organs it's affecting. So this is a very complicated diagram of, the process and how heme is made. You can see heme is kind of, up here in this corner. And in EPP, the enzyme, the step in the process of making heme that's not working correctly is the ferrochelatase. The way you can think of this more simply is that, when you have the plumbing in your house, there's various pipes that bring the water into your house. You use the water. The part of the process that gets, quote unquote, used by the body is the active heme. It's incorporated into the red blood cells. It transports oxygen around the body, then eventually gets broken down, and you have various drains to drain that water out of your house. In each type of porphyria, there is a blockage kind of along each in various parts of this piping system, and it kind of leads to overflow at that particular step, and those are the porphyrins that accumulate. So the main types of porphyrias, this is kind of like how they're grouped based on both symptoms and treatments. There are the acute hepatic porphyrias, which are ones that affect the liver more than the skin. The most common one is acute intermittent porphyria. Most patients with acute intermittent porphyria or AIP have little to no skin symptoms, and it's mainly a liver and a nerve problem. There are a couple, there's this very uncommon type of porphyria that looks a lot like AIP, and then hereditary porphyria and variegate porphyria mostly affect the liver, but they can also have some blistering in the skin. Variegate porphyria blistering is very uncommon, and in hereditary porphyria or HCP, it's a little bit more common. Then we have the blistering cutaneous porphyrias, including Porphyria cutanea tarda. This is the most common. Sometimes it's genetic, but we also see it kind of come up in people who have things like hepatitis C or who are on dialysis. Congenital erythropoietic porphyria, or C, very severe form of blistering porphyria, and hepatoerythropoietic porphyria is another blistering porphyria, also very rare. But today we're mostly going to focus on acute non-blistering cutaneous porphyrias, which means that patients have mostly skin symptoms, uncommon liver issues, but they don't form blisters in the skin.
Excuse me for interrupting, but people are having trouble hearing. Could you get a little closer perhaps to the speaker? Sure. Thank you, Dr. Saardi.
Yeah, absolutely.
Thank you.
Let me see if I can change the sound settings too. Okay. The volume, is that any better?
Yes, that's better.
All right, when it comes to EPP and XLP, the X-linked form of protoporphyria, these are both inherited in what's called a recessive manner. So in your body, there's 2 copies of every gene. And this is kind of like a redundant system or a backup system because you have 2 copies of each chromosome. Chromosomes are the parts of the cell where it's basically DNA and protein, and that's what holds the genetic material, your genetic material in each cell. This is true except for the X and Y chromosomes in male. Genes are essentially what tell the body how to make each protein. EPP, we used to think it was autosomal dominant, but now we kind of understand that the majority of people who have EPP have one gene that's severely affected, and the backup copy is not as severely affected, but there's still some mild issue with it. And this is a term called compound heterozygosity. And heterozygosity just means 2 different genes. Homozygosity is when the mutations are the same. In other words, you have the same severe mutation in both genes. It does occur, and it tends to be a more severe form of EPP, sometimes with a higher risk of liver issues. With X-linked protoporphyria, only one gene is affected, but there's no backup in male patients. And that's why it's mostly male patients that are affected by X-linked protoporphyria. So just to touch on the genetics of autosomal recessive, generally parents will be carriers. In other words, they have one normal gene and one affected gene, and there's a 25% chance that the child will be, one of their children will be affected. With X-linked recessive, such as X-linked porphyria, basically dad can have a mutated gene, but if he passed a mutated X chromosome, but when he passes it on to the daughter, she gets a normal gene from mom no matter what, so she's not affected. The son, however, because they only get one copy of the X chromosome from dad, they're also, because they only get one copy of the X chromosome from mom who's not affected, they are also not affected. In the reverse case, where dad is not affected and has a normal gene on the X chromosome, he'll only pass along, the normal gene to daughters, and passes on the Y chromosome, which actually doesn't have the gene at all, to the son. Mom, however, can be a carrier, can pass it along to a daughter, but she gets a normal copy from dad. But when she passes along that X chromosome to the son, to a male, child, they are affected because they don't have that backup. So what are the symptoms of EPP? I'm sure a lot of people, in the room know way more about this than I do, but this skin is most commonly affected. It usually shows up in infancy or very early childhood, usually before age 4. Within minutes of sun exposure, there's severe pain in the skin, can be described as burning, stinging, tingling, prickling. This is followed by redness and swelling of the area. Sometimes the swelling, gets to the point where the skin actually turns white, almost like you'd see with certain types of hives. And it lasts anywhere from a few minutes up to a couple of days. The liver can be due to gallstones. This is true in a lot of different types of porphyria. And with EPP, the feared complication is liver damage due to the buildup of that protoporphyria. Nerve damage, can occur, thinning of the bones. This is maybe part of the disease process, but sometimes, we also worry about just how much we have to protect people with EPP from the sun, the vitamin D levels, getting very low. And then anemia, which is also very common in various types of porphyria. So we got a lot of questions about liver disease in EPP. It's due to buildup of the protoporphyrins in the liver. The issue is that the liver also helps get rid of protoporphyrin. So this buildup and this mild, kind of low-level damage that's happening to the liver actually worsens the liver's ability to get rid of protoporphyrin, and it kind of becomes this vicious feedback loop, or a vicious cycle where liver function gets a little worse, can't get rid of the protoporphyrin as well, so it builds up more and damages the liver more. and kind of spirals out of control in some cases. One of the biggest risk factors that we've seen for developing liver damage in EPP is another condition that also damages the liver, such as hepatitis from like hepatitis B or C, what we call NASH, non-alcoholic steatohepatitis, or fatty liver disease, and excess alcohol consumption. Detecting the liver disease is very difficult. Some people who just have very high protoporphyrin levels, throughout their lives seem to be at higher risk for it. When those protoporphyrin levels start to rise, that can be a sign that the liver is not getting rid of them as well as it used to. Some patients report that their skin sensitivity gets worse, again, due to the buildup of the protoporphyrin. And then the liver tests, by the time they become abnormal, that's actually pretty late in the disease process because the liver has a pretty good capacity to regenerate and heal itself. So by the time the liver is not able to do that anymore and the liver function is becoming abnormal, that's usually where things are starting to become a little bit dangerous. So what developments have we seen in protoporphyria, and what are some of the challenges that are still going on? So on the genetic side, genetic testing has become very affordable. In my clinic, in patients who have not had genetic testing yet, we kind of just do this targeted testing, which includes 3 genes, including the gene for the typical form of EP, this new gene that I'll talk about in a second, and the X-linked porphyria. It costs less than $200, and it's almost always covered by insurance. Now, I've never had issues with insurance coverage for these kind of targeted testing panels for a specific disease. About 5 years ago, there was a new gene that was discovered that causes a condition that is essentially EPP. The gene that is normally affected is fetch or ferrochelatase, and they discovered this CLPX gene. It's not actually involved in the heme production system, but it helps some of those steps along. And now we found this kind of additional gene where we kind of know a lot of the variants that cause EPP in the fetch gene, but this new CLPX gene that was discovered does seem to explain a lot of those cases as well. In terms of liver transplantation, over the past 10 years or so, there's been a lot of interest in what's called domino liver transplantation. In EPP, the majority of the protoporphyrin that's produced and is causing the issue is made in the blood and the bone marrow, not so much in the liver. And for a lot of other metabolic conditions where there's a problem with an enzyme due to a genetic mutation, what's been attempted is for someone who has a metabolic disease like EPP or other things and requires a liver transplant, they'll give them basically a normal liver transplant from someone who's dead or dying. We call it deceased liver donor. And they can actually take some of those livers in these metabolic conditions and give them to someone who has liver disease from another issue like hepatitis, medications, alcohol use, etc. Because there's really nothing inherently wrong with the liver in EPP or in other metabolic conditions. And this has actually been attempted in EPP, and there's a lot of interest around this because you can essentially give 2 people a liver transplant where in the past you'd only be able to do 1. So some of the treatments that have come out, alpha-melanocyte or Scenesse is the brand name. This is an implant that goes under the skin every 2 months. Basically tells the skin to make more melanin, which is the protein that gives the skin its tan color. So I like to say it's tanning without the sun. Very safe medication in my experience. Some of the side effects are just a little bit of pain at the implantation site. Usually gets better over a day or 2. Some people have noticed that their moles might change or they might develop new moles. To my knowledge, no skin cancers or melanoma has been reported with alpha-melanocyte. Sometimes people feel a little bit nauseous. The thing we worry about is allergic reactions, which is true of any medication. Sometimes those can be severe, including things like hives and anaphylaxis with throat swelling and trouble breathing. So it's usually given by a doctor in an office or an infusion type place. And then there's suggestion that people might be more susceptible to things like coughs and common colds. So some of the treatments that are being studied, cimetidine, which is a common antacid medication, the over-the-counter name is Tagamet, appears to work for other porphyrias, and there have been some reports of it in EPP. There is an ongoing study in the United States for this. There's a medication called bitopertin, which is not on the market yet. It was tested for schizophrenia, and it didn't really work, but it actually appears to lower protoporphyria levels, also being studied in the US at a variety of places. And then a medication that's very similar to alpha melanotide, the name, they kind of medications like almost like code names before they give them a real name. It's called dursimelagon. It's almost like a pill option that does a very similar, that works in the similar way to the alpha melanotide. It's currently in what's called a phase 3 study where they're testing it on people who have EPP. And this is usually the last step, to getting approval for a medication. So challenges. One of the biggest challenges when I got involved with EPP is kind of answering the question of who takes care of porphyria patients. It's kind of funny because porphyria is something that basically everybody learns in medical school. It's like one of the first things you learn in like kind of the biochemistry, very introductory courses. You learn about this whole pathway of the porphyrins and how heme is made. But surprisingly few doctors are familiar with porphyria and have seen porphyria patients. So my question is always, is it a hematologist that's taking care of you? Is it a dermatologist, a geneticist, a hepatologist, a liver doctor, a neurologist? And there seems to be, kind of a lot of, there are differences in how each center, allocates porphyria patients to various specialties. So that's something that, can be confusing both for us as doctors and patients too. Why is it so difficult to find and get care for porphyrias? I think part of the problem is that no specialty has really taken, major ownership of porphyria as a group of conditions, because it can affect, a wide variety of organs. But also, some of these, treatments are very expensive, and particularly with, the Scenesse, the alpha melanotide, there are very few places nationwide that do it. More and more are, getting on board and starting to do this particular treatment, but there's still a significant, travel time associated with getting it. Sometimes there are insurance issues for getting some of these new treatments. And the other one that we'll touch on in the Q&A is accurate testing for porphyria. In the United States, there's really two major, labs like Quest and LabCorp. Neither of them has really a very comprehensive, set of porphyria tests. And then your other labs, your reference lab, like the one in Texas, the one at the Mayo Clinic in Utah, a lot of these places don't have their like standalone, buildings where they can actually draw your blood and do that testing. So getting accurate testing for porphyria is a little bit difficult. Luckily, genetic testing has become much accessible. And I think that that's going to be, one of the major ways that I think that things are going to shift and we're going to move over to a more genetic-based diagnosis. And, another question that we got from multiple people is how do we predict liver disease? And that's still kind of an unknown, but we'll touch on that in the Q&A session. So we've got a list of, questions from people in the audience and people who are attending about, protoporphyria. So, I did my best to answer them here. I also tried to, kind of shorten the questions and remove some personal details. And the first question was, is it possible to have EPP with a normal protoporphyrin level? I would say yes, definitely. And the main issue with that is that you need to be sure that the lab that was done, the test that was done for the protoporphyrin level, was that the correct test was ordered, the blood was collected properly and handled properly before it got to the lab. These specimens need to be, protected from light. They recommend, as soon as the blood is collected, the tube actually needs to be wrapped in aluminum foil, either refrigerated or frozen, and then shipped to the lab. So if it wasn't handled correctly, that can definitely affect the testing. And again, going back to that issue where it's very difficult to find a lab that will do this testing, like a standalone lab that you can just walk into. The issue that we've had at our institution is that we only are able to, in our building, we only have a LabCorp location, And when I tried to order total and metal-free protoporphyrin, they will administratively change the order to zinc protoporphyrin, which is a test for lead poisoning. That's not the test for EPP, because it's basically someone kind of almost like just changing the order because that's the closest thing that they see. They will not actually realize that this is a different test and route it to the correct lab. So we've had to kind of find a way to do the testing correctly. And if there's any questions, like I said, genetic testing is very affordable and very accessible now, and can be definitive. Next question was, without having your protoporphyrin 9 levels checked, what are the symptoms possibly indicating liver problems from high levels of protoporphyrin 9? Is it possible to detect it? Maybe. Predict it, that's kind of a little bit based on genetics. People who have 2 very abnormal genes for EPP seem to be at higher risk for developing liver disease down the line. If the protoporphyrin levels at any point are very, very high, even without rechecking them, that does seem to be a risk factor for developing liver issues. And then there's been some suggestion too that worsening skin sensitivity can be a sign of those protoporphyrin levels rising, and some people report that that can be a symptom that the liver is not doing as good a job as it needs to be to get rid of the protoporphyrin. Do liver issues or liver failure increase in people with EPP as they age? I would say maybe, probably, because the liver failure is not very common in children. Whether that's due to age is not really clear. We know that people as they get older, when you turn 21, you're allowed to drink alcohol, and that may play a role. People kind of become like sexually active and can contract things like hepatitis and whatnot, and that can damage the liver. So there may be other issues, including things like obesity. So it may be a little bit of a coincidence that these other liver problems happen mostly in adulthood, that the liver failure in EPP happens then. But yeah, it doesn't seem to be as common in children. Do people with mild EPP only have children with mild EPP? The answer is usually. So in certain ethnicities, up to 10% of people are carriers of EPP. And again, you have to have 2 abnormal genes in order to transmit it. But if your partner has 1 abnormal gene, there's about a 50% chance the child will. But at most, amongst all the potential partners you can have to have children with, it's about 5% if it's just completely random. If there's genetic testing done on the partner, if the partner's not a carrier, then there's a 0% chance the child will have EPP, unless there's a spontaneous mutation, which is very, very rare. If they are a carrier, and they're a carrier for a severe gene, there's a 50% chance that the child will have EPP, because you'd be transmitting 1 severely abnormal gene and 1 that's only slightly abnormal. And if your partner has a severely abnormal gene, there's about a 50% chance they'll have EPP. And if they're a carrier for any gene, including a more mild form, there's about a 25% chance that the child will have EPP. There's also a lot of different, you can do, that's called preconception testing, when the partner of someone who's affected with a genetic condition is tested. And then if that person is a carrier or is affected, you can go through a in vitro fertilization, which is a form of conception where the egg is fertilized outside of the body, and they can actually test those eggs for certain genes before they implant them, selecting for eggs that only or actually embryos that don't have the genetic mutation, and that can reduce the risk of transmitting certain genetic conditions to almost 0%. How's liver damage from EPP treated? If it's detected early, things like plasma exchange, where they remove the plasma, in other words, the fluid and protein that's not the cells in your blood, they remove all of that and give you replacement plasma to get rid of the replacement plasma that doesn't have any protoporphyrin in it, to lower those levels very quickly. They can also give hemin, which is kind of it's almost like an artificial heme that kind of slows down porphyrin production in the body that's used for other types of porphyria. If it's caught late, and with these things, the liver function doesn't recover, it may require liver transplantation. Oftentimes they'll do the same thing after the liver transplantation, because the liver, until it gets kind of situated and up and running, doing what your old liver used to do, it's not very functional. So they'll often do that to reduce the protoporphyrin levels very quickly until the liver can start doing that for your body. Are bone problems common in EPP? Yes, and the big reason for that is that vitamin D. Up until very recently, we didn't really have much we could do for the symptoms of EPP other than have people just be very, very strict around sun exposure and activity in the sunlight. So low vitamin D levels are very common. That's part of the blood test I do for everyone with EPP once a year to make sure that the vitamin D levels are hopefully normal, but also not very, very low, because that can lead to early bone problems, including osteoporosis, fractures, things like that. All right. That's all I have for you guys, but I'm happy to stick around and take any questions. I think we had, allocated almost at least another 15 or 30 minutes, right, for questions.
Right.
Yes, we've got a couple questions in the chat.
Sure.
One of them was, what levels of protoporphyrin levels outside of RBCs is quote unquote very high?
Usually less than 80 is considered normal. But it can be, in the thousands. I don't know if there's like a strict cutoff that we consider very high, because everybody's a little bit different. Most of the results I've seen have kind of been in the high hundreds to 1,000 to 2,000 range. There's no specific level that I can say is very dangerous. Because everyone's body handles it a little bit differently.
Okay. And then another question was, if you could please circle back regarding heredity, if dad has XLP, EPP, and which gender child it may be passed to. That weren't sure when you were going through that.
Yeah, so with the XLP, if dad is affected, when in determining the sex of the child, it's really which chromosome they inherit from dad, and mom is not affected. So each child gets a normal copy of the X chromosome. Daughters will get a copy of the abnormal gene on the X chromosome, not affected, because they have one abnormal gene and one normal gene. And sons are also not affected because they get the Y chromosome from dad, which doesn't even have the gene for XLP. When the carrier, sons who only get the one X chromosome from mom, if there's a 50-50 chance that they'll inherit this abnormal gene from mom, they will be affected because they have no backup copy. Other 50% of the time, they'll get a normal gene from mom and they won't be affected. But daughters can become carriers if they inherit the abnormal gene on the X chromosome, or they can be totally unaffected and not a carrier.
Great, thank you. We've got a question that might be more, it looks like it might be about acute porphyria, but I just figured I'll throw it your way. Says, I'm still having issues with diagnosis. Many 24-hour urine tests protected and sent to Ottawa during attack, and then they're waiting on their genetic test, it sounds like. So maybe that just kind of speaks to what you were saying, that it's difficult with some of the biochemical testing, but genetic will show it no matter what, kind of. Is that what? This wasn't really a question.
It will catch the majority of cases of acute porphyrias. We have now that genetic testing has been around for a very, very long time, most of the variants that cause porphyrias are known. But like I said, in 2017, the EPP we've known about for decades, and just 5 years ago, they discovered a completely new gene that can cause EPP. So a lot of these companies that do genetic testing, even if they don't find anything the first time around, a lot of them have a clause when it comes to testing where after some companies it's 1 year, some it's 3. After a certain amount of time, they'll actually allow you to have the genetic sequencing that they have already done for you, to have that reanalyzed against anything that's been added to the database since the first time it was analyzed. So we're still discovering new things, but with how quick and affordable genetic testing has become, it's become quite easy to diagnose things with genetics. The other thing is with the acute porphyrias, the urine test is a good test for when people are having acute attacks, but in between attacks, there's certain testing that can be done too that may suggest a porphyria. It's different for each type of porphyria and what test needs to be done. Some of them are blood, some of them are actually done on stool. There is testing that can be done between attacks to detect that as well.
Great, thank you. The next one is, if you can take a couple more questions. Can liver function be managed naturally with healthy diet and alcohol abstinence, or will persistent porphyria levels and aging liver eventually cause liver function to decline anyway?
No, yeah. So we call it protoporphyria hepatopathy. Happens less than 5% of the time. Like in terms of lifelong risk. So a lot of people, never experience any issues with the liver at all. But those are great ways, to manage and prevent it. Avoiding alcohol, healthy diet, especially, in a way that avoids like obesity and fatty liver disease. It was actually just probably about five years ago, maybe, that non-alcoholic fatty liver disease actually had become a more common reason for liver transplantation than alcohol abuse. Because of kind of like the obesity epidemic. So yeah, healthy diet and avoidance of alcohol are definitely two good strategies to make sure that doesn't happen.
Right. And here's one: are there different methods to help combat anemia in EPP patients?
Ooh, that's a good one. I was just talking to somebody about this the other day. It's not clear if so patients with EPP can have a little bit of anemia. And we don't know if, correcting that anemia is helpful or harmful, because we don't know if adding iron to the body to kind of stimulate that heme production, we don't know if that leads to faster buildup of protoporphyrin 9, or if it kind of relieves that pressure on the bone marrow to make those red blood cells and slow down porphyrin production once the anemia is fixed. So we just don't know. Definitely, if there are symptoms from anemia, that's a good reason to fix that, because that's going to kick that porphyrin process into overdrive, trying to make more heme to fix the anemia. But in terms of like mild anemia, it's a difficult question. I don't think people have a good answer for it yet.
Okay, great. Can you take another question?
Yeah, absolutely.
Okay. Are patients with EPP eligible for live transplants? And we're based in Canada.
For like a living related transplant or a living, unrelated? I believe so. A lot of places are switching, to doing more live transplants. The worry with the live transplant is that they can't give you the entire liver. Obviously, they can only give you a small portion of it, because the problem is not actually in the liver. Like for people who have liver disease from hepatitis or alcohol or fatty liver disease, a small amount of a small part of a liver can actually be enough for them to live without any issues. But because there's still a little bit of pressure on the liver from the protoporphyrins being high, I'm not sure if everybody would be a candidate necessarily. But what's also being done for some of these metabolic conditions is what's called sequential transplantation, where they'll actually do a liver transplant and then they'll do a bone marrow transplant afterwards. Bone marrow transplantation is curative for EPP. In other words, the condition goes away if the bone marrow is replaced. Obviously, with somebody who doesn't have EPP's bone marrow, for instance, you have someone with EPP happens to also have leukemia and they get a bone marrow transplant, they will not have EPP after that. And the main risk with any kind of organ transplant is that the immune system has to be suppressed for a long period of time. So the thought is that if you have to suppress the immune system for the liver, there's not that much added risk if you also have to do it for the bone marrow. So these what they call sequential transplantations are being done. But yeah, I'm not sure if anyone has done. I think I did come across some reports of it being done, but they worry that a small portion of a living donor's liver may not be enough if the problem is still going on.
Okay, great. There was a really great question from Dennis. What source can I use to educate my son's school? With kids having problems at school, needing to be protected and having to kind of fend for themselves.
It's kind of funny. I would say, there's stuff from the Porphyria Foundation. There's also another condition where children are very, very sensitive to sunlight called xeroderma pigmentosum. They have some of the best. I can send either Desiree or someone else the information, but they have a very extensive list of precautions and resources for people that are sensitive to the sun. I think they even have resources for like schools and camps. There are some camps kind of in the dermatology space where the children will go to summer camp, but the summer camp is held entirely at night with other children who have photosensitive conditions. But I'll have to get you guys the information about the xeroderma pigmentosum site, because that's been the best resource I can find for kids who have sensitive skin, sun-sensitive skin.
I can also, this is Desiree, and I can answer about what the APF has done. And we advertise, or not advertise, but we educate about the different camps. And we've also created books for children that are very helpful, and we've set up a pen pal system where they can talk to each other, which has been good. And of course, we have social media groups. We have the website, and try to get as much television as we can, because that's where they learn. But we really do need to learn. We really do need to make some better resources. So that's, I'm glad you let us know about the XP site.
Yeah.
And by the way, the French, they have Sylvie Lamolle is on this call, and she's the head of the French group. And the French have a camp for EPP, just EPP kids. The ones that we have here, there are for a lot of dermatological issues, but some of you might want to contact the APF and we'll tell you how to reach Sylvie.
Right.
Oh, and one more thing. We have Hat Day during Porphyria Awareness Week in the past, and hopefully again this year, that Hat Day, we ask the schools to let everybody wear a hat. And we then use that day and that time so that the kids themselves can describe EPP, let people know why they're cut up, why they can't, say, go play with the recess with like other people. So we will get that information about Hat Day out. It will start coming out in the next 2 weeks, I believe, where your kid can, in his or her school, be able, we've got information for the school and for the classrooms and how to set up Hat Day.
Great. There's one other question that's related to this. Where can we seek treatment for a youth with EPP? What ages are the treatments available for? And what comorbidities or medications limit those treatments?
So the alpha-melanocyte Scenesse is FDA approved for people above the age of 18. I think it probably varies center to center if they're willing to, treat anyone under age 18. I am willing to, and I think the main barrier to that would be insurance coverage. Getting no matter what the treatment is, getting things covered for quote unquote off-label use can sometimes be a challenge. The people that do our insurance approvals for the CNES are very good. Sometimes it's just a matter of writing a letter. Other times it's a matter of speaking to the doctor for the insurance company and explaining to them that, yeah, this is off-label, but there's really no other treatment right this second. I haven't had any issues with it, but I also haven't tried for anyone under age 18. I'm perfectly willing to, but I think that's going to vary center to center.
Great. Well, thank you so much, Dr. Saardi. This was so informative. I know I learned a lot and we got to a lot of questions. So thank you for your time. You sure were doing a lot today. So thanks so much.
Yeah, absolutely. If there's any additional questions, feel free to email me a list and I can get back to you guys.
Perfect. Thank you so much.